Good afternoon, everyone, and welcome. I'm really pleased to see you all here as you join in the third critical conversation talk. Actually, it's going to be a conversation, and I really want to welcome friends from within the university and outside the university as you come to listen what's going on in the global health. Before I introduce our speaker, I want to really take a moment and thank Dr. Pavani Ram. She really has worked hard to put together the events for last couple of days. Yesterday, there was a very interesting and engaging panel discussion where Dr. Borrazzo, as well as Pavani and others participated, and there were students from high school as well. So really a great event. I've gotten good feedback. So Pavani, thank you very much for all that you did. My thanks also to Dr. Borrazzo and our faculty and students, as I said, who have been really participant in that. We had a lunch today with distinguished faculty members, a very engaged discussion ranging from startup companies to global health and what's going on in the world. So really a great event. I personally feel that this is an event that gives our campus and community a chance to sort of stand back and think about the issues that may not be daily issues for many of us. And these issues that are important in an interdisciplinary manner. These are not the issues that I, as a computer scientist, or somebody as a physicist or English professor, thinks about these every day. So we want to bring people who have experiences and who look at these things from an interdisciplinary nature. And that's really what we have today in our speaker, right from his training. He's trained as a physicist, the first degree, and then he worked in industry for a while. He's a New Yorker. And then he got his Ph.D. in civil and environmental engineering. And you can see the sort of movement towards more of humanity as he went along in his job. So he's really got the whole spectrum of disciplines that he has worked in. And I'm really very eager to hear about his experiences and what are the major challenges in women's health and in children's health worldwide. So with that, I would like to invite our distinguished speaker here. Thank you.
Okay, well, is this mic on? Okay, so thanks for that kind introduction, and thanks to all of you for the warm welcome I've had here over the last day and a half. I really appreciate it. I want to thank President Tripathi for the warm welcome and for all the events that have been put together. Thank Pavani Ram, who I've known for a long time, for all the good work she did organizing this. Thank Connie Hulleman and others in the Office of the President for all the work that they did to try to pull this together, including trying to make sure that I was delivering what I needed to deliver on time. And thanks to all of you. And I think that this opportunity for a conversation, it seems to be a relatively small group. So I'm not going to, I said it's impossible to listen to anybody speak for 40 or 45 minutes. So I'm going to try to speak somewhat shorter than that, and then hopefully we get an opportunity to have some dialogue back and forth. First, I always say know your audience. So first, let me just check my audience real fast. So how many of you are faculty from the University of Buffalo? University at Buffalo, excuse me. How many of you are students of one stripe or another here? Okay, well, University at Buffalo students. Okay, are there any people from outside the University at Buffalo community? Oh, well, just a couple. Okay, great. Well, thanks. So I focus my attention on this idea that we can actually end preventable child and maternal deaths in a generation. That's what that's emerged as the theme of what we've been trying to do at USAID, amongst other things, over the last couple of years. And it helps really to focus one's attention. I'm going to talk to you a little bit about the ways in which, where are we at, what we're trying to do, what will it take to get there, and although I think President Tripathi already alluded to some of this, does it really matter what your college degree is in? So we'll come back to that at the end. This photo I took, I visited a clinic actually it was a clinic that was converted to a first-level hospital in Lusaka, but now about a week and a half ago. And I think that they need a little bit of marketing here, because I don't think you necessarily want to end with the mortuary right after your maternal and child health services. But I mean, the reality is that in so many places in the developing world, pregnancy and childbirth is a very risky proposition. My colleague who runs our maternal health programs uses sometimes an old proverb that apparently is an African proverb that goes something like this: to be pregnant is to have one foot in the grave. Just highlighting that, in fact, this is a very risky business. We started this push instead of saying we're just about trying to improve maternal and child health, to try to focus people's attention on mortality reduction back at what we called the call to action in 2012. And it was very much focused on child, and I will talk about child and maternal, but you'll probably note that I sometimes spend a little bit more time talking about child. It's a little bit more of my background and comfort zone. But this was launched at a very high political level. You'll see a presidential candidate in the photo there. But at that time, oops, don't hit the wrong button. At that time, the idea of trying to end preventable child deaths was a novel idea. We were in the middle in 2012 of the final push towards what are called the Millennium Development Goals, and they have a deadline, for lack of a better term, of December 31st of this year. MDG 4, which was focused on child mortality, spelled out every country should achieve a reduction of 2/3 in its under 5 mortality rate. And that would get countries to a certain point, but because it's a relative reduction, a country that started in 1990, which was the baseline, with an under 5 mortality rate of 300 or even 200, would still have a very high under 5 mortality rate if they, in fact, quote unquote, succeed in meeting the MDG target. So we've laid out a new idea, really a bold vision for what the world could look like. And instead of everybody achieving a relative reduction, that every country would be below a certain maximum threshold for under 5 mortality. It attracted a lot of political attention. And we got to this point not just by pulling a number out of the hat, but by trying to think through what's feasible. And we tried different target years, and we tried not only different target years, but trying to look at what the target should be. And what we came up with was a target of getting every country below 20 deaths per 1,000 live births by the year 2035. And we got there by, I'm sorry, I keep hitting the wrong button. We got there by looking at what are countries currently doing in terms of their annual rate of reduction under 5 mortality, and what they would have to do to achieve this ambitious goal of 20 per 1,000 by 2035. And you see that the sizes of the circles are actually proportional to the number of deaths in those countries. And you could see that among many of the largest, I'm sorry, these buttons are kind of small. Many of the largest countries in terms of numbers of deaths, and most of these are very large countries to begin with, are also ones where, in fact, the required acceleration in this annual rate of reduction in mortality needed to be the greatest. And what we're trying to do is to look and see, okay, is this range, is this necessity of achieving 8 or 9% reductions in mortality, is that reasonable? And if we had actually gone to a target either more aggressive than this, and there were some who wanted to, or a target that was pulling us back from 2035, shorter term, that these required rates of acceleration would exceed what's ever been seen. I mean, countries that are, I'm sorry, I keep hitting the wrong button. That was pretty bad. And so the idea was that we wanted to put something out there that was ambitious, but reasonable, and it worked. So a lot of my discussion is going to be talking about, where have we been at in this policy process? Where has it led to? Where is it going? But this idea worked. And the other thing that came into clear focus is that when you look at where deaths are occurring, roughly half of the child deaths in the world are taking place in 5 countries. India certainly is not surprising. I mean, most births are in India. About the same fraction of the world's births are in India. The others are ones you would potentially anticipate. Some of the bigger countries in the Africa region, along with Pakistan. President was able to get on board. President picked this up, and if you work in the federal government, you're really getting the line into the president's speech is what it's all about. Now, it's actually a little bit of an exaggeration, but certainly getting a line in the State of the Union message that said, we're going to save the world's children from preventable deaths, that actually came directly from essentially this analytic work that had been launched the year, not quite a full year before. The Lancet, Global Health 2035, December 2013, actually picked up on this idea of a grand convergence. And first they noted that there's been extraordinary economic progress, and that if you look at where countries were in 1990 in terms of income strata, you had 3.1 billion of the world's people. So that was roughly, I can't see that, a little bit more than 57%. We're living in low-income countries, but the world continues to get richer. That's a good thing. The world is getting richer. So a much smaller fraction of the world's population is in low-income countries. But if you look at where essentially, let's not look at the TB side, but let's look at the child side, although the stories are similar. If you look at where the deaths are occurring, the deaths are disproportionately in low and low-middle income countries, of which one big low-middle income country is India. So we're seeing change. The world is changing. The world is changing in positive ways. But the deaths still are disproportionately, as you might expect, in low and low-middle income countries. So this idea of a grand convergence is that if we're starting at a certain, if our starting point is, the analysis was done starting in 2011, and we're looking at these different scenarios in terms of both low-income countries and then lower-middle-income countries. They have different starting points, but that there's a convergence by 2035 of what could be achieved. Now, that idea evolved a bit. Still has momentum. This was taken at the end of August. These are the ministers of health from all over the world, all surrounding Prime Minister Modi, who really, he did his own call to action. It was a global meeting. It was actually, again, with us and others. But we have the call to action. We've had, I'll come back to the acting on the call in a second. But the idea of this convergence, the idea that it was possible to achieve something momentous was then became folded into the Sustainable Development Goal dialogue. And if you've been tracking this global policy effort, you know that a few weeks ago at the United Nations General Assembly, the Sustainable Development Goals were adopted. And there's, as I mentioned in yesterday's panel discussion, there are 17 targets, 17 goals, and there's 169 targets. But the thing that was most gratifying is that the targets that we had put out there for child mortality and a similar kind of effort around maternal mortality, although they were reflected in different ways, this idea of being on a road to ending preventable child maternal deaths had traction. And you look at this and, okay, well, you say, well, gosh, you were just talking about 2035, and all the SDGs are for 2030, or for most of the targets are for 2030. Well, what we did was we actually just tried to, I'm really sorry. We tried to make an adjustment, for saying, well, okay, you can't get to 20 by 2035. We're not going to have 2035 targets, so how would we make some adjustments to both for targets that would be applicable in 2030? So I think that this target, which is the SDG target for child health, getting every country to 25 deaths per 1,000 live births or fewer by 2030, it can be directly traceable to this effort that we launched in 2012. And we're very pleased that it played out that way. There's a similar kind of effort, although the SDG target is different. We also have essentially a country target that's associated with this, but it's not in the SDG target itself. This is rather a global average maternal mortality ratio. So at the SDG Summit in New York, there was the launch of a global strategy for women's, children's, and adolescents' health. And so the idea is, okay, you've got a target. How are you going to get there? And this was a massive effort. It was a consultation. The whole thing was organized by the UN Secretary General's office. Okay. And while there are many different things, many different directions this could have gotten pulled in, one of the things that we appreciated was essentially the continued emphasis on trying to end preventable deaths. So we've got essentially an analytic effort that led to high-level policy adoption by governments of the world, and now we're at the stage where we have to actually take a strategy forward and use this strategy to actually define country-level action. And having specific targets is really the key thing in terms of focusing attention. We almost didn't get these targets. And if we hadn't gotten numeric targets, I don't think that the momentum that has been established behind the MDGs would have been sustained beyond 2015. And having this is really, really quite valuable. Now, the starting point then, we said we got into a certain point in 2015. Some things have worked well, some things haven't worked as well. But we know what the challenges are. We sit here in 2015, and we know that still around 300,000 women die every year from pregnancy-related causes. We know what some of those... Jesus. I'm getting pretty angry with myself about these buttons. We know what some of those major causes are. 52% from three leading causes of maternal mortality. Hemorrhage, sepsis, and hypertensive disorders. And I'm going to come back to where this fits within the full spectrum of things that potentially affect mortality outcomes for women of reproductive age. We know that we've got some key child health challenges. The best estimate we've got right now for the number of number of under 5 deaths in the world is, for the first time, at least the first time since these measurements have been undertaken, or these estimates have been undertaken, first time under 6 million. So that represents, roughly a halving of the number of deaths from 1990. That's a significant accomplishment. 2.7 million of those deaths are amongst newborns, meaning they're in the first 28 days of life. And there are a lot of reasons for that, but amongst the single biggest cause for newborn mortality is preterm birth, and also infants born small for gestational age. We've got, I'm so sorry, that the stillbirths issue is put in parentheses because, well, there's actually you'll hear numbers about stillbirths, but we really don't have good estimates of stillbirths. What we do know is that many of the things that we do to help prevent newborn mortality should also have an impact on stillbirths. But there are other interventions, frankly, that haven't been explored, and this is one of the frontier issues. I think if you're looking to engage in maternal and child health, one of the areas that's least understood is stillbirths, both in terms of the magnitude of the problem as well as interventions that might be specific to stillbirth issues. And that's an area that's considered one of the frontier issues for this next generation strategy. When we look at the causes of under 5 mortality, well, one would think that would be a straightforward question. It's really not. It's hard to estimate the causes of under 5 mortality. There was the Child Health Epidemiology Research Group. That's where the paper that this figure is derived from came from. And that paper indicated, that was where we have the current estimate, that around 44% of under 5 deaths are in the newborn period from a variety of causes, including, I need either a bigger clicker or smaller fingers. This is, some of those actually overlap. There's pneumonia that takes place during the neonatal period, but pneumonia itself is then the single largest cause of under 5 death outside of the neonatal period. Diarrhea has been consistently declining as a cause of under 5 death, although still is the third leading cause. Malaria globally is 7%, but that's a little bit it's a little bit misleading because in the Africa region, it's often the second leading cause of death. So we have to look at some of these issues regionally as well. I'll come back to that. And then finally, the last slide I've got is where we stand in terms of environmental health challenges. You may have known also that there were under Millennium Development Goal 7, there were targets for having the numbers of people without access to adequate sanitation and clean water. And you may have heard that, well, we did really well on water. We met the water target, and no, we didn't meet the sanitation target. That's a little bit simplistic, because even though the water target was met, that doesn't mean everybody's got safe water. I talked about this. I've had so many different conversations, frankly, at this point. I don't even know when I said what, but at some point I said that about the safe water issue. And the reality is that that the environmental health challenges remain an important part and an important contributor to what we need to do to continue to improve maternal and child health outcomes. And the other issue that's emerged as a critical one is the issue of equity, because as overall average levels of mortality have declined, it's also clear that the discrepancies within a population, the disparities within a population, by various indicators, but one that's a little bit easy because we've got some objective ways of estimating it, is by wealth quintile. And you compare what's going on in the richest quintile versus what's going on in the poorest quintile, or you look at things stratified by mother's education, you can see just huge differences in outcomes. And so how do we actually address the issue of inequity in outcomes is actually a critical part of our agenda going forward. Where are the deaths occurring? Well, if you looked at the picture in 1990, there were roughly 12 million under 5 deaths, and more than half of those were in the Asia region. So the Asia is the gray. And then you look at where we are in 2015, and we've got about half as many deaths, so a much smaller pie. But in fact, you can see that the fraction of those deaths that's in Africa is now close to half, and the number of deaths that are in Asia is actually much reduced. That reflects a couple of things, but largely it's reflecting a disparity in under 5 mortality rates between Asia and Africa, but also an increasingly larger fraction of the births that are taking place globally that are taking place in the Africa region. Now, the Institute for Health Metrics and Evaluation at the University of Washington also maintains its own estimates and its own database of causes of mortality. They look at this by cause, they look at it by risk factor, and there's a couple of interesting things you can play around with this. They've got some great data visualization tools, and you can play around with this and try to gain insights into what some of the differences are between regions or between populations. And if you compare Asia and Africa and look at the causes of death for those who are under 5, you can see that a couple of things. One is that there's a big box in the Asia region. There's a big box in the Africa region that's really small in the Asia region. This NTD, neglected tropical diseases, and malaria, that's basically all malaria for the most part. There are although there's a lot of burden from neglected tropical diseases, visceral leishmaniasis, or other helminthic diseases, the reality is that the NTDs and malaria, the deaths piece is largely malaria. So malaria is a much bigger deal, as you might expect, in the Africa region, and relatively non-consequential in the Asia region overall, which means that the role of neonatal deaths is really significant. I remember you said globally about 44% of under 5 deaths were in the neonatal period. Well, now we're looking at roughly maybe 60% in the Asia region, and still maybe only about 1/3 in the Africa region. So there's a big difference in terms of what we might be focusing on looking forward in the Asia region versus what we might be doing looking forward in the Africa region, where we're still dealing with substantial malaria deaths and we're still dealing with problems of diarrhea and lower respiratory infections, primarily pneumonia. So it's a different picture, and how that different picture plays out against different kinds of programs and programming is actually an important factor. The other thing you can look at is risk factors, and these are categorized in different ways. I've just lumped them under behavioral risks, which include things like inadequate breastfeeding or smoking, versus environmental risks, which are things like inadequate sanitation. And the red bars indicate the fraction of the box that's accounted for by those risk factors. And as you might expect, the behavioral risk factors, which include things like behaviors that relate to nutrition, account for a lot of the nutritional deficiency mortality. a substantial portion of the diarrhea and pneumonia mortality, and relatively little other group 1 is other infectious diseases. But if you look at the environmental risks, they really play out mostly against diarrhea and pneumonia mortality. And there's some obvious risk factors, either inadequate sanitation or household air pollution, or a couple of others that actually play out against that as a risk factor. We look at the deaths of women of reproductive age. So this is a standard measure of women ages 15 to 49. And we look in general at higher income, more developed countries versus lower income, less developed countries. And the blue boxes, that's all non-communicable diseases. The red boxes, those are infectious outcomes and maternal and adverse outcomes of pregnancy and childbirth. And the green boxes are injury, both largely unintentional injury, but also injury that, let me get this right, injury that relates to self-harm and interpersonal violence. So most of this is unintentional, but some of it is actually intentional. And so when you look at this, there's a couple of very big differences between richer countries and poor countries. The big difference is that in poor countries, those red boxes are a lot bigger, okay? And the thing that's still astounding, not astounding, but if you think about it, it's realistic to recall this, is that the maternal health fraction of overall mortality of women of reproductive age is still the minor fraction in terms of causes of death. It's still a very significant and preventable outcome, but it's one that, in fact, represents only one of a number of things that essentially are risks for women for mortality during this period, during this age group, during this age period. The other way this breaks out regionally is also quite different. I mean, the big difference, it's clear and apparent when you first look at it. There's two big differences. One is that the HIV and TB box is just so much bigger in Africa than it is in Asia. And then the second piece is that the maternal causes represent a larger fraction in Africa than they do either in Asia or the previous slide globally. So that idea of maternal requires attention is something which is it's within the framing of ending preventable child and maternal deaths. It's very important. It's significant. But within the framing, if we were trying to really address women's health during reproductive age, there's a lot of other issues to consider. And so, there's a little bit of a tension there because there are lots of other things going on with cervical cancer screening and potentially other things that could have huge impact on women's health at this age. But we're focusing and continue to focus on maternal health outcomes. So we did this call to action in 2012, and in 2014 we called together another event with 24 countries that we've said we want to work with you. 24 countries that account for 70% of under 5 and maternal mortality. 16 of those countries were in sub-Saharan Africa for some of the reasons I've already just discussed. And so we had in 2014 acting on the call. We're going to have another event in June 2016, which will be, after you call to action and you're acting on the call, I guess the next thing is, I'm not sure what. Is it acting like you're acting on the call, or we're still trying to figure that one out. But what we did was we now have an annual report, and this was the first one in June 2014, and this was the second in June 2015. And what it really tried to do was say, let's lay out for every country, let's spark a discussion about what's going well, what's not going so well, and where we should try to place emphasis, time, energy, resources. Not just USAID, but collectively, the global community focused on this, including the countries themselves. And some countries are doing quite well. You look at a country like Bangladesh. This is its historical rate of progress. This is past, roughly, this direction. And this is future. And you can see that the kinds of reductions that they've been consistently able to show over time is not that different from what they would have to do to be able to continue to stay on track to meet this goal of ending preventable child maternal deaths. And the acting on the call methodology actually went through and looked at the different contributors to that continued mortality reduction in terms of different kinds of interventions: treatment of childhood illness, malaria interventions, immunization, child nutrition, neonatal health, maternal health interventions, what they would contribute to under 5 mortality. And this is the distribution in terms of what would contribute the most. So the way we use this programmatically is we say, okay, this doesn't mean that this is not prescriptive. It's not giving us an answer, but it's sparking a discussion to say, okay, if there is a problem, if there is nothing going on, if there is nothing going on in our programs that relate to immunization, and yet that could have a significant impact, let's understand why we're not doing it. That's the way we're trying to use this kind of analysis and this kind of thinking, this kind of information. And you look at other countries. DR Congo is a very different kind of scenario than Bangladesh. In more detail, you can see, okay, here's history, and here's the curve that DR Congo would have to be on to try to really meet this goal of ending preventable child deaths. And it's a pretty sharp breakpoint. There needs to be a substantial acceleration. And so the question then becomes, all right, even more importantly than in Bangladesh, what do we need to do differently? What can we help do? What's the way in which we could be supportive of accelerated gains? And clearly there's a couple of things that come up repeatedly. Immunization comes up repeatedly. In the case of DR Congo, water, sanitation, hygiene, comes up as a significant issue. I'm trying to see. The treatment of childhood illnesses. That's what child health means in terms of this legend. Treatment of child illnesses lagging in terms of treatment of pneumonia, diarrhea, and also to some extent malaria. So there's ways in which we try to use this information to give us essentially insight. Don't hit yourself on the chest when you have a mic on. Okay. So 2015, our graphics people tried to come up with a way of representing, are we making the right kind of progress, the progress we anticipated on some of these key interventions. And I have to stand corrected because I said, my gosh, nobody's going to like this. They had this this is a racetrack graphic. So the idea is that the dots indicate what needed to change, what was the rate at which something needed to change, and these are the different interventions. Right, so here's this one. This one says, sorry, just to read it myself, improved water. So you trace this around, and improved water, it's in orange because it's not quite making the target that it would need to make, the rate of progress it would need to make to be considered on track. So apparently everybody loves this graphic. They love the idea of the racetrack. So yeah, Pavani, you say no, okay. So the graphics people, they won out though. So we've got a racetrack now to keep track of whether our interventions are progressing at the rate we'd like. The other thing we did with the acting on the call this year was because we really had not done an adequate job of it last time, was really look at what would be the impact of maternal health interventions on maternal mortality outcomes. And there's some clear things that we try to emphasize. So really trying to shift over time, and our time horizon for this analysis was through 2020, really trying to shift over time away from home delivery and much more to delivery in facilities that can offer comprehensive care. And the anticipated that would actually overall institutional deliveries would increase, and then you could actually project based upon that, oops, I'm not supposed to pass that, I'm sorry. Based upon that, what would be the impact on the impact of scale-up on these various causes of maternal death? Is it coming from essentially getting people into basic care or coming people into comprehensive care? It turned out that actually just that first shift, getting people out of home delivery into first-level facilities, actually turns out to be quite significant. So, this does, again, I'm just trying to really emphasize the way in which we at USAID, we don't have answers, but we can certainly try to use this kind of analysis to help raise the right questions. And then you think about, this is the kind of part that's reflecting some of the conversations we've had over the last day and a half. The role of universities is to continue to help to inform some of the answers to those questions. Because I think that we've now got some of the right questions. And I want to come back. again, to this idea of implementation science and what it means at the end. Now, what are some of the things where we think we're moving along and getting better? So, newborn health. I mentioned earlier that a larger and larger fraction of the deaths of children are occurring in the first 28 days. We know that as countries' overall under 5 mortality rates decline, as is the case in much of Asia, that the fraction in the newborn period gets larger and larger, and that newborn is still particularly, I want to say unaddressed, it's getting more and more addressed, but that there's a lot more work to be done to improve newborn health outcomes. The partnership that was put together around the Every Newborn Action Plan actually is quite vibrant and has been a very effective advocate for, not only advocate for programming, but actually getting things done. And for example, the Helping Babies Breathe, it started as a curriculum with the American Association of Pediatrics, with the AAP, but then evolved as part of a public-private partnership to also include manufacturers of low-cost resuscitation devices, figuring out ways of getting those into every place where that they're needed, and actually then doing some careful evaluation work, what the impact has been. And Tanzania is probably the country that's furthest along with this. And in the places where HBB has been rolled out, it's seen a 44% reduction in newborn mortality. Again, that's not necessarily a national figure, but in the places where it's been done successfully, it seems to have substantial impact. Another, well, that's weird. Another is family planning. Family planning is just so critical to this overall agenda, and there's a couple of reasons why. One is particularly on the maternal mortality side. Fewer pregnancies means fewer risks of death during pregnancy. Reducing the number of pregnancies reduces the risk for a very real live woman. Right? Now, it gets a little trickier when we talk about the reduction in number of deaths from family planning that results in fewer pregnancies, because then you're not exactly saving the life. There's the lives of children who were never conceived, so the number of deaths of children actually declines. So family planning is important from a couple of different perspectives, but it's also important, and this is, incidentally, this is an analysis that was done by the Copenhagen Consensus, which looks broadly at all kinds of development issues, and their analysis said that the benefit per dollar spent for access to contraception was second only to trade liberalization. So the kinds of things they look at are very broad, and this really emerged as something that was very significant. But there's a couple of different ways. So women's survival is better if you actually help to ensure that women are healthy at a healthy age for pregnancy and delivery. And also if they overall have fewer children. And this is not just an impact, this is an impact on the maternal and mortality ratio. So it's actually not, this is not the impact from just having fewer children and having fewer risks over the course of your lifetime, but it's actually the risk of, it's actually decreasing the risk of maternal mortality for any given pregnancy. And it's also good for the kids. And this really comes back to one of the core messages around why family planning is important to ending preventable child and maternal deaths. It's that under 5 mortality really benefits from healthy spacing, typically around 36 months is optimal, as well as nutritional status. And nutritional status, as we'll see in a moment, is linked so intimately to mortality outcomes that, in fact, anything that we can do to improve nutritional status also, in turn, helps to reduce mortality. Immunization is one of the core public health interventions. We work closely and have increasing contributions to the global, well, to Gavi. It's now called Gavi, the Vaccine Alliance. Gavi used to be called the Global Alliance for Vaccine and Immunization, thus the name Gavi. But Gavi, the Vaccine Alliance, we were one of the founding partners for Gavi. It's a public-private alliance. We're no longer the biggest funder of it. Well, I think Gates has always been the biggest funder. But we pledged in January $1 billion to Gavi over 4 years. And that's a significant contribution because it has to come out of maternal and child health funding, and now represents about 30% of our maternal and child health budget. So that's actually a little bit less right now, but we anticipate it's going to go to about 30% with this $1 billion commitment. So we have to make sure we get something for that. And the thing that's great about immunization is that it's we're fairly readily able to translate increased availability of vaccines to increased immunization coverage to essentially mortality and deaths averted. And Gavi's got a very clear message about that. Over the next strategy period, they'll immunize 500 million kids. As a consequence, they'll save 7 million lives. And that resonates very well, and it's a very strong and powerful and simple message. It's probably fairly accurate, too. I mean, we've talked a little bit in some of our other discussions about how do you communicate uncertainty. At least immunization is one of those things that's a really good public health buy, and the outcome is pretty clear. Even with the newer vaccines, which are higher costs, they also have large impact. A number of those countries where I showed you the green slice of those pies, where immunization was going to have a big impact in child mortality, a lot of that was from the expansion of access to pneumococcal vaccine for countries that haven't already introduced it. So there's good momentum behind this, and the key thing we have to try to manage at USAID is how do we integrate this large Gavi investment with other things that we may be doing at country level, which is a challenge. Pneumonia and diarrhea, I remember I said earlier, they remain globally the second and third largest causes of under 5 mortality. And if you look at the 15 countries with the largest burden of pneumonia deaths, and you look at the 15 countries with the largest burden of diarrhea deaths, they're pretty much the same countries. And this came out of, I was part of this paper that was in The Lancet when we launched the Global Action Plan for Pneumonia and Diarrhea. And the argument of the paper was that, one, in higher mortality countries that still have fairly high under 5 mortality rates, so we're talking really more about countries in some parts of Africa, particularly West and Central Africa, this issue is not getting enough attention and really requires much more attention than it's gotten. So again, we can't forget about pneumonia and diarrhea. And the reality is that we've got some good approaches. We've got new vaccines. We've got some new case management options, relatively new. I mean, low osmolality ORS has been around for 10 years. I can't even say that. But with zinc, that's been around for about 10 years now. We've got countries still shifting and adopting amoxicillin, but also potentially adopting policies that allow amoxicillin to be distributed at community level, which is also significant. And then finally, we've got that there are that we are gaining more insight into what works in terms of prevention. And we've got insights about the best ways to promote hand washing, still with a lot of challenges. We certainly know about the risk factor of indoor air pollution. We're still trying to learn more about how to actually address it. I'm going to skip this one too, because just the bottom line is the yellow box, which is that there's overlap in terms of the point of application of some of these. Essentially, we try to treat treatment of pneumonia and diarrhea in an integrated way. We can look at the household environment as something that can be looked at in an integrated way. So I think we're trying to figure out new approaches for pneumonia and diarrhea because, in fact, this field needs a little bit of invigoration, this part of the field. Malaria, I said it was huge in Africa. You might recall those square box plots where malaria really was a significant factor in sub-Saharan Africa. We know that the work that's been done so far, and USAID, or the U.S. government, actually launched the President's Malaria Initiative in 2005. It's been part of a global effort surrounding increased efforts around malaria. And the Global Fund for AIDS, TB, and Malaria is also involved. Others are involved. But I mean, the reality is it's had a significant impact. I mean, one of the take-home lessons is that focused interventions with money behind them can have real impact over a not very long period of time. And we've seen dramatic reductions in malaria mortality rates, about 2/3 for children under 5. That's very significant over a relatively short period of time. And there's not that many different things that are going on. It turns out, when you look at the analysis, that I deleted the slides because I didn't want to get into this much detail, but 2/3 to 3/4 of the reductions in mortality we're seeing are just coming from the bed nets piece. The bed nets they're out there at scale and they're making a difference. There's questions about how this effort will be sustained for the long term, but they're making a difference today, and that's important. And this is the kind of impact that's actually has been measured. If you look at the parasitemia rates in different parts of Africa, which are in fact now they are able to relate these to the clinical presentation of malaria in facilities. Think of this as roughly a surrogate for essentially for clinical presentation of malaria. And what you find is that the areas in 2000 that were relatively high, there's been a substantial decline in in parasitemia in Africa. And so this is a significant change. And I think that it's a good example. It's such a good example that now there's a momentum behind trying to think about ways, especially with new, albeit not entirely as effective as we would like, vaccines for malaria potentially coming online in the next few years, that there's the opportunity to look at really eliminating malaria by mid-century. And certainly the Gates Foundation is all over that. That's one of the things that they've been pushing for. And the estimated contribution that malaria interventions have made to overall declines in under 5 mortality have ranged from about 18% up to as high as 55%. The bottom line message, even though every one of those numbers is imprecise, accept that, realize that, is that malaria programming has had a big impact on under 5 mortality in Africa. Nutrition is responsible or associated with, not responsible, it's too strong, is associated with about 45% of under 5 mortality and about 20% of maternal mortality, primarily, malnutrition, and usually undernutrition in this case. Undernutrition, responsible for about 45% of under 5 mortality or associated with 45% of under 5 mortality and about 20% of maternal mortality, primarily through anemia. And the thing that's complicated about nutrition is it's so fundamentally an intersectoral issue. It's the combination of dietary preference and social cultural factors, the combination of just lack of income to pay for food, the ability to actually absorb nutrients, the whole issue of food security being this combination of availability, accessibility, and other factors. So the idea of nutrition as an outcome is a complex intersectoral, within the universe of intersectoral approaches to maternal and child health, nutrition itself as an outcome is something that requires a lot of intersectoral action. And we have a multi-sectoral nutrition strategy in USAID. This is recent, and it actually addresses some of these key issues. Water and sanitation actually is a key part of this multi-sectoral nutrition strategy. It looks at protein energy malnutrition as well as micronutrient deficiencies. For me, it was a very significant event because it was the first time that multi-sectoral dimension for nutrition was really clearly articulated. And also, it finally brought, when I started getting interfacing with this community, the nutrition community was a world at war with itself. You had the micronutrient people and then the protein energy people, and they were both, there was no way to integrate those visions, right? And so now they've actually got, at least for us at USAID, there's a way in which this has been articulated as something which is, it's all important, and we're trying to figure out a way to make it work programmatically. So the bottom line message is that kids are stunted in the same place where they're dying from everything else, okay? That's an easier message. I'm going to skip that. The key message here is that diarrhea mortality and pneumonia mortality are very strongly linked with whether an infant is breastfed or not. And that's a huge reduction in the odds from 15 to 1 reduction between an infant that's exclusively breastfed versus an infant that's not breastfed. And the same for diarrhea mortality. So this issue of nutritional status and its impact on diarrhea and pneumonia mortality is a really critical one. So the other thing that's emerged is that we do all this work to try to understand what interventions are going to have the biggest impact. And then in the mid-2014, there was the culmination of some work that was done by something called the Partnership for Maternal, Newborn, and Child Health that actually looked at, okay, so how much of our understanding of interventions does the observed reduction in mortality, how much of that can be explained? Well, it turns out that these top two boxes, these are very health-specific interventions, like immunization coverage. And these are more systemic interventions, like getting women into facilities for delivery. So those are things that we measure a lot in health programming. And that accounted for about half of the reduction in mortality. Now, other factors that really seemed to be important were basically women's status. Power relationships, population dynamics. For example, is the total fertility rate declining? Education, and a lot of these are all related, okay? Environmental management, meaning primarily access to water and sanitation. Economic development, huge piece of it. I mean, these are not necessarily these are not unexpected, but we don't necessarily program towards those other ends very effectively, at least not in a coordinated way. This is a topic of much current interest. So the kinds of discussions we've been having about the way you're trying to pull together different perspectives on development problems in the university, that's a reflection also of a discussion that's taking place in the broader community. Because the ways in which we can actually get not only at this, but working in some coordinated way to maximize the impact, maximize the impact of all of this, to mortality outcomes is a programmatic challenge. When I was at the UN General Assembly meetings a few weeks ago, there was launched, you'll love this, the Alliance of Alliances. So it was the people, the Sanitation Water for All people, the Global Alliance for Clean Cook Stoves, the Partnership for Maternal, Newborn, and Child Health, all lined up. They were going to be an alliance of alliances. So still trying to figure out how that's going to work. I want to wrap up with a couple of comments about USAID. So USAID is the government's lead development agency. It's not just about health at all. It's about economic development. It's about democracy and governance. We do a lot of work also in humanitarian relief. We work for ending preventable child and maternal deaths. We've lumped this a number of funding streams because they all contribute. So it's not just maternal and child health. So I have responsibility for maternal and child health, but it's also family planning funding, it's also malaria funding, it's also nutrition funding. And these are the 24 countries in which I mentioned earlier we focus. We focus on those countries because not only are they responsible for 70% of maternal and child deaths, but they also provide good opportunity for making a difference. So it's both need and opportunity driven. And you can see some of the countries, clearly have substantial funding, like Afghanistan, Nigeria, Ethiopia, DRC. There's a number of smaller programs out there. And then I just wanted to give you a snapshot of what our funding picture looks like. So state and USAID have a combined budget request with line items, for separate line items for USAID. The largest single health line item, though, is state's budget for the President's Emergency Plan for AIDS, PEPFAR, AIDS relief in Africa. Anyway, PEPFAR. It's not get to the point when you use acronyms, you don't even remember what they stand for. But the HIV/AIDS programming. And so that's all of this stuff in red for the most part. So the three big blocks in the way we try to characterize our programs now are creating an AIDS-free generation, this segment here, which is on ending preventable child and maternal deaths, and then infectious disease, basically keeping the world safe in terms of infectious diseases. This slice on ending preventable child and maternal deaths breaks out this way. The blue is maternal and child health. And remember I told you this is the slice out of maternal and child health that's now going to Gavi. Okay, this is the FY16 request. I mean, nobody knows, this FY16 budget is still in process, but this is what the President's budget requested. And then there's a good chunk that's family planning, another good chunk that's family planning. Look at nutrition funding. Nutrition funding is actually quite small. And that's why it's important to look at nutrition as a multi-sectoral issue, to look at how it can lever, for example, agricultural development funds and other things that are out there in terms of trying to improve nutritional status. So I wanted to end on that. Does it matter what you major in? I was a physics major. I was never really a physicist, but I was a physics major. Ended up as an environmental engineer, found a pathway that got me to working on something I care passionately about. And I'm glad to have been able to spend a couple of days with you, talking about this, and the small group discussions were great. So again, thanks very much. What am I supposed to do?
Well, I just wanted to say thank you so much, John. And I think we could take just one or two questions if there are any. I see one in the back. Biplop? Please introduce yourself, and maybe you could tell us which discipline or department you're from.
Hi, I'm Biplop Bhattacharya, and I'm a first-year Ph.D. student with the Industrial Engineering Department over here. So my question is that preventable deaths are, we've seen that it's primarily in low and middle income countries. And we know that their healthcare systems are generally overburdened already. And the aim is to reduce preventable deaths, which will in turn then increase the demand on their healthcare system. So is there anything that is being thought of to tackle that aspect of it?
So absolutely. I mean, there's a slide I didn't use, which is essentially an estimate of how the population requiring services will increase over time. And you're right. But the way in which those preventable deaths will be ended is going to be through stronger systems. So it's not as if there's a sort of and there's going to be these vertical efforts to say, let's tackle this cause of disease, and then we're going to turn them over to the health system. The health system is the vehicle through which many of these interventions will be implemented. So I don't think that that's a primary concern, because the idea is that, and increasingly for USAID, our work is going to be to try to strengthen systems, not to deliver services. So it's not as if a donor or others are going to come in and just save lives and then say, okay, now you in the health system have to take care of these people forever. So it's through the strengthened system itself. Yeah. Was that enough of an answer to your question?
Yes.
Okay.
I'm Phil Stevens. I teach anthropology here. My experience is in sub-Saharan Africa. One area I think it may be a problem that I didn't hear you cover is child pregnancies among pre- and adolescent girls, which really needs to be reduced.
Right.
It leads to serious problems.
Right. So I didn't talk about it, but it's clearly something that's at the forefront of the post-2015 agenda. Part of it, it's global political leadership that gets behind it. So one of the things, I was at this meeting last week in Zambia, and part of the meeting was of this Partnership for Maternal, Newborn, and Child Health. And the chairman of that group is Graça Machel. And for Graça Machel, this is the issue that she wants to leave as her legacy of leadership on this group, is ending child marriage. And the fact, she said she's willing to do one meeting a year of PMN, of this group in Africa. And what was significant was that because the meeting was in Zambia, we had the strong statement of commitment from the government of Zambia to end child marriage. And so, building that momentum is important. The technical message was buried in there, which is that it's not just about timing and spacing, but it's about essentially reducing risk reducing risk of early pregnancy by essentially minimizing early pregnancy. Because it's clear that girls of 13, 14, 15 having children are at very high risk. So that issue is clearly one that's on the forefront of the post-2015 agenda.
I think we have one last question on the other side.
Hello.
I can't see you because there's a large spotlight in my
That's
eyes.
fine. My face isn't quite.
I'll come over
My
here.
name's Hannah, and I'm a master's in environmental engineering here. And my question is, what took
My old field.
I know. I have a kinship with you. So my question is, what took so long for the idea of alliances? Because in my opinion, I feel like that would be the most efficient way to make progress if everybody's funding is sort of on the same page, but you sort of laughed about it like it was a crazy idea.
So I think the wording is a crazy idea.
True.
I think the idea is a good idea, but the challenge right now is to figure out what the Alliance of Alliances will do. I'll tell you a story. So I was in Congo a little over a year ago, and ended up having to travel over land because there was a complication. I ended up having to travel over land. It took 6 hours to go 100 kilometers, which is, about 12 miles an hour. And the reason it took so long was that there really wasn't a road to speak of. There was a lot of dirt and sand. And everything was being moved in this corridor by people pushing things on bicycles. So my attitude about the Alliance of Alliances is not that we need a global alliance of alliances, but what we need is a more successful dialogue at country level so that the fact that a road could potentially be your most effective public health intervention is somehow factored into the equation of discussions amongst those who are trying to do something at the country level. And that's the kind of thing that I think an alliance of alliances could help support. They could actually try to bring those issues to the table through partners at country level. And I think it makes a lot of sense.
Do you see a lot of that happening or beginning, or?
No, I think that's what we're trying. The other big thing about these Sustainable Development Goals is that everyone is focused, and the global strategy is focused on the need for improved action across sectors. And I think that the challenge right now is to figure out how to make that happen. Because you don't really want to have another sort of global secretariat of alliances. But what you want to have is effective dialogue at country level.
Thank you.
Yeah.
Thank you so much.
Thank you.
So I'm Pavani Ram, and I'm representing the Community for Global Health Equity. I wanted to take this opportunity to thank John Borrazzo, who's been here for the last 2 days. It's been my sincere honor and pleasure to know and work with John over about a dozen years now. And John, as you can tell, based on his description of his recent travels, is an incredibly busy person, and he's doing a lot at the forefront of preventable maternal and child mortality and representing the U.S. government in ways that I think all of us can be proud of. And so I'm deeply grateful and honored to call you a colleague, a friend, and a critical conversation speaker here at the University at Buffalo. I also wanted to extend my sincere thanks on behalf of the Community for Global Health Equity to President Tripathi for allowing us to have this space, these couple of days, to have a lot of thoughtful reflection around the community, around what we're trying to achieve here at the university. So again, thanks to you. And thanks so much, sincerely, to Connie Holloman, who has done tremendous work to make this program happen. So to you and your staff, thank you. And thanks all of you for coming, for all of the interest that you've shown in these activities over the last couple of days. For those of you who don't know and are interested in getting in touch with the community, it's very simple. Send us a note, globalhealth@buffalo.edu. We'd love to let you know about our events and about ways that you can get engaged in these really important issues facing the world today. Thank you.